How interesting.
So, good afternoon, ladies and gentlemen, and a warm welcome from a beautiful and magnificent Cape Town. It gives me great pleasure to welcome our panel over here at the annual Stump the Professors course. And the Stump the Professors include a whole lot of numeraries. And as is our tradition, we don't give a bio on everybody. I'm just going to give you their positions. If you wish to know who they are and what they've done, and these people are certainly people of the highest caliber, I'm going to ask you just to Google. And Professor Stephen Jeffrey is sitting right next to me. He's a person that needs no introduction, certainly won't get one from me. He's a urogynecologist, and I've always said, Steve, I rate you as one of the 10 best urogynecologists in Cape Town.
That's good.
Then with me,
rankings are going up.
Yeah, things are going up. Then we have Professor Jan-Paul Hoovers. He's a urogynecologist. He's professor and head of Amsterdam, and he's known well to you, Sherry Palm. He speaks very highly of you, in fact, to Professor Hoovers. He's going to be our second panelist. We have Lisa Welsh, who's an accredited sex educator. Lisa, if you can, there you go, raise your arm. Thank you very much indeed. And she's based in Durban of South Africa. Then we have Deline van Dijk. We have a bit of an echo over here. Thank you. Deline van Dijk is a psychosexual educator and a counselor and a sexual health nurse. And she's a person of great experience. We also have Clayton Hall. There he is, Clayton Hall. He's a medical malpractice defense attorney and consultant to the insurance and healthcare injuries. And finally, we then have Sherry Palm, the trailblazing founder and CEO of Association for Pelvic Organ Prolapse Support. And she is based, in fact, as a vocal educator, advocate, and author based in the United States of America. So this is our final one, Steve. And I'm going to start, ladies and gentlemen, by thanking our sponsors, who's MediChallenge. And just before we start, Denisia Stricker is going to say a few words on behalf of MediChallenge. Denisia, please, Corin, can you put her in?
Yes, Denitsa is here. She should just, there we go.
There we go. Thank you, Karen, for tricking me to come on camera. Good evening, all. I'm Denitsa, and I'm medical and marketing manager at MediChallenge. Firstly, I would like to thank Professor Jeffrey and Dr. De Jong, and of course your entire team for the opportunity to support this wonderful educational platform throughout the year. For us in MediChallenge, it is important to disseminate accurate and relevant information to both patients and healthcare professionals through best clinical practice in the field of menopause and pregnancy maintenance in order to increase the awareness in the safety of the registered body-identical hormonal drugs. So we are very proud to be able to assist women from their young age through fertility to maternity and menopause. I would like to thank the organizers and the panel of speakers, experts, for their tirelessly working to educate further your peers and improving patients' health, women's health, and quality of life. Thank you again, and I hope you enjoy the webinar, and happy holidays.
And I'm just going to play a quick 2-minute video that Denitsa has provided for us. So if you just give me a second.
Thank you very much indeed, Denitsa. Thanks, Corin. No rush, Corin.
MediChallenge, your trusted partner in women's and men's health. MediChallenge is a wholly owned subsidiary of Bizarre Healthcare, a global company with registration and partnerships in 93 countries worldwide. MediChallenge specializes in women's health products with trusted brands such as Femigel as transdermal 17-beta estradiol, Utrogestin as micronized progesterone in softgel capsules available in 100 and 200 milligrams, and Mifegene as mifepristone 200 milligram tablets. MediChallenge also recently launched the first registered transdermal testosterone, Androgel. Femigel provides relief of symptoms due to natural or surgically induced menopause with invisible percutaneous once-daily gel application that is easy and allows for titration of the required dose. The risk associated with transdermal hormone replacement therapy given in standard therapeutic doses is no greater than that of the baseline population. You can consider transdermal hormone replacement therapy for women who are at an increased risk of venous thromboembolism, including those with a BMI of over 30 kilograms per square meter. When the use of progesterone is necessary, micronized progesterone is considered the safe alternative. For more information on our products, please feel free to contact any of our sales representatives, Yajna, Mandy, Michelle, and Mike, or send an email to denitsa@medichallenge.co.za, or visit our website www.medichallenge.co.za.
Thank you very much indeed. And that was a most interesting video. Thank you very much indeed. May I begin the webinar then? Is that okay, Corin?
Yes, please do.
Thank you very much. My first question, ladies and gentlemen, and if anybody has a question of our audience, please feel free to email them, send them. Corin's standing by to take your calls. It's for Sherry Palm, who's the founder and CEO of the Association for Pelvic Organ Prolapse Support. Prolapse, Sherry, in general terms, is a huge problem for many, many women. And some women have been disadvantaged by all sorts of things, including surgery that hasn't been up to their expectations. How do you, as an advocate for women, make patients more visible and let their voices be heard?
We use many of the traditional tools for that. We have got, obviously, we have got both an open and a closed patient support forum space. So as the comfort level varies from woman to woman, and they need to, once they discover they have prolapse, because that's a big piece of the equation here. Women don't even know prolapse is a condition until after they're diagnosed. And so them coming into one of our two spaces, finding us, they Google their symptoms, they find us, they then kind of diverge into two different paths. Those that are not comfortable talking about what they're experiencing, and those that are comfortable talking about it. And that kind of steers them in the direction that they reach out to us and they start communicating out loud about their conditions. We find by and large that when they come into our closed patient support forum, first, that gives them a comfort zone because women talk about everything in that space. We've got right now, there are just a hair short of 26,000 women, and they're in 183 countries. So teens through end of life, they talk about every aspect of prolapse, and that's a key piece of the puzzle here, getting that comfort level, recognizing they're not the only person who has got that, which is a common misconception. They think it's just me that has these symptoms. And then from there, it kind of blossoms. Sometimes they shift quickly into an empowered state, and sometimes it takes years to get there. So depending on, their individual personalities and backdrops. So obviously we use all the social media tools everyone else uses, but by and large, our support forums are our strongest base for helping women find that comfort zone, recognize what they're experiencing is not unusual with this condition, and getting answers that they need to empower themselves and move forward with their lives.
Thank you. Thank you very much indeed.
Yeah, I mean, on that point, and I mean, just it's amazing to hear what you guys are actually doing and how they're providing a platform. There are quite a number of informal platforms that I'm noticing here in our part of the world, and I have started to get patients through those forums. Patients communicating from in South Africa, from the Eastern Cape up to Namibia, and communicating, and I think one of the bigger issues is obviously the pain syndromes, etc. and the mesh issue. So, but I mean, people are communicating on those forums. Maybe not as much as in the US as in the UK. Yeah, it's. Have you noticed that at all, Pete?
I certainly have, and I think it must enter the mainstream discourse, Sherry. You know, we're having in Cape Town in 2025 FIGO. I'm not sure if you're aware of what FIGO is. This is an international body made up of obstetricians and gynecologists throughout the world, and one of their remits is advocacy for women's health. And I'm hoping that you in 2025 will be able to share with us here in this beautiful city of Cape Town these advocacy issues that are raised and that need to be raised, because I feel that although the women have been our patients for so many years, they are still many times still disadvantaged in their profile, and we need their voices to be heard. So thank you very much indeed. And just a final word, and thank you very much indeed for applying with us your mind on this Thanksgiving Day in America. And we wish you all the very best for Thanksgiving 2023. Thank you. Where are you based, if I may ask?
I'm in the Milwaukee area, so I'm in the Midwest, right in the middle of the U.S. And
Milwaukee. Where did you say? What city?
Milwaukee, Wisconsin.
Oh, Wisconsin. Okay.
And so we're about 2 hours north of Chicago.
Ah, that's where they make
David.
Okay, thanks so much then, Sherry.
I just want to bring something else into you, and again, it's great that you joined us on this holiday weekend. Thanks so much, Sherry. But Clayton, are there any legal issues that we need to be aware of? Because I mean, obviously there's a very tight sort of interaction in this whole realm of patient, communication and social media, and I mean, is there anything that we need to be aware of in terms of patients reaching out directly to us, sometimes even on a WhatsApp, getting our numbers from another patient? I mean, there's obviously a potential minefield here. What do you suggest?
Yeah, no, I mean, there definitely is. Thanks for the question. I think, anytime you put yourself in a situation where, you're a professional and your words have the potential to be taken as advice or as professional advice instead of, as a response just to a comment or a question, you always put yourself at risk because, in the clinical setting, when you're asking questions and answering questions, you have the patient's history, you have the option to ask a whole bunch of information, you usually have a bunch of context and medical history behind that. And so that all forms part of the advice that you give, and that's what often makes it professional advice. You're applying your experience, your knowledge, and the context in order to provide that advice. So yes, I think, consider very carefully what you're saying and make sure that it doesn't constitute advice, that it's factual, that it's up to date with whatever the latest thinking actually is. And then sometimes if that is changing thinking, it's something that you should put a timestamp on. So when you do publish something or put it onto social media, you can always make the mark that says, this is relevant as at this time, and maybe get a lawyer to write a very small disclaimer or for you to go with those posts as well. But certainly the risk on WhatsApp and seeing that as quite an informal platform is that you can get lulled into a false sense of security where you almost stop seeing someone as a patient and see them too much almost as a friend or an acquaintance that you can chat quite freely with, but that is a risk area. And so I'm not saying don't be friendly with your patients, but just be conscious that when they are engaging with you, they're doing it in the context of seeking professional advice. And so when you're giving advice, know that you must be certain that it is that, or don't give the advice.
Thank you, Clayton. On that very point, if I can come in over here, we have an anonymous caller. His name is Habib, and he wishes to remain anonymous. His question is this. He has a patient that came in for a pap smear, and the patient was anxious and had to be counseled. And afterwards, he had a very vitriolic phone call from the patient's mother. And the mother threatened on behalf of this particular anxious patient who had the pap smear, who actually then had to go for colposcopy. The mother said the mother said that she will advertise negatively his name on the WhatsApp and social media. What is the correct approach to this sort of conundrum? Clayton?
Yeah, another good question. So also, I'd just like to say this this is a strong trend at the moment. I think in the last few months, I have probably received calls or questions from easily 15 different situations where a patient is seen and the mother is upset and calls, and the practitioner, when that in this case, there was somebody who was anxious. But for, I'd say, 80% of these cases, there is zero indication from the patient whatsoever that there is anything wrong, that they're upset in any way. And then, within a day or two, you get these vitriolic calls from the patient's mother, just often quite abusive and making all kinds of allegations. And especially around this, I'll put your name on the internet, I'll put your name in various places. So, I mean, the correct response to that is to not ever admit that you've done anything wrong, first of all, because usually you won't have a clue in that situation what you may have actually done wrong, because often the complaints are not necessarily very precise. And to say, I can't discuss anything to do with the patient with you, because that is private medical information. If I don't have consent from the patient, I can't disclose it to you. So we can't discuss this. If you are aggrieved and the patient is aggrieved, please feel free to bring them with. If they're comfortable to have a conversation with you present, then they can give that consent to me, and we can have the discussion. Be more than happy to sit with you and try to resolve your complaint. But it must involve the patient. That's usually what I counsel. It's not a requirement, but I find that tends to be the right approach. Often in some of these situations, patients don't tell the truth to their parents. Sometimes they're covering for something, or they're trying to almost put up a smoke screen so that they don't have to discuss what the results of the tests were. And so sometimes it just isn't false, and that can often just put it to bed, because the patient doesn't want to come and have a conversation, because what they're complaining of wasn't quite exactly as they've explained it. In those situations. But certainly with the advertising negatively, there are two general responses to that. Either if it is a serious allegation and you truly believe this person is going to do it, to get a lawyer's letter to just confirm, if anything is done, we will of course seek legal recourse against you, and also the cost of having to do so. But in a less formal way, you simply say, if anything like that does happen, of course it would be false, and so we would have to seek the normal legal recourse against you if you were to put anything out there that is defamatory or that affects my practice in any way.
Okay, thank you for that, Clayton. Yes, Sherry.
Quick question here. I'm a little confused on WhatsApp is not very commonly used here in the US. And so I'm curious, when are practitioners having conversations on WhatsApp with their patients, as opposed to, just in-office consults with them? I mean, here it's like extreme rarity that a practitioner will communicate with a patient via email, that kind of communication. It's pretty much, if you have a need for additional conversation, you have additional anxieties about what's happening with your body, etc. It's an in-office consult. So for a parent of a patient to be intersecting in this, I mean, obviously there's many different conditions that we're looking at here on this panel, and being prolapse specific, I'm thinking about, our backdrop, but we just don't see WhatsApp communications about this health condition that we navigate. So I'm kind of curious about that, how that works.
Yeah, absolutely, Sherry. We have quite a traditionally, a lot of us do have quite open communication lines with patients. I personally receive a lot of email from patients. A lot of patients will phone the office and ask for a phone call back, and especially on a post-operative level, patients that we are concerned about, we will interact through WhatsApp quite not infrequently. It's obviously requires a little bit of wisdom as to which patient you give your phone number to. But yeah, no, absolutely. So patients will very, very frequently call our office and ask for additional conversations, information, and we do we do that for better or worse. I mean, it's yeah, just out. And Pete, you get calls and emails from patients all the time, don't you?
Yeah, and you know, we must just remember that WhatsApp is not confidential. No matter what WhatsApp says, it is not actually confidential. And for that reason, I would say it would be better if you phone me, call me, and make an appointment, because we cannot discuss any intimate disorders on WhatsApp. It's just like putting everything on a banner. That's the way.
But it
it's
is
just
encrypted,
not
Pete. I mean, it's
encrypted. It might be, Steve, but it's still not confidential. And I wouldn't ever give any person any advice over any media, because I don't think it's right. B, I don't think it's confidential, encrypted as it might be. And C, I think it's a very difficult medium. Better for them to come into the office or call, and we can do it that way.
Right. Right.
Now, if I can just go to.
but there are 2 hands raised. I mean, I think
All right, yes, all
JP's got something to say, so maybe we should, and then obviously, and then Clayton's hand was up actually as well.
Okay, JP.
Yeah.
Just turn your mute off. Here, let me unmute you. There we go. Now you're unmuted. Go ahead.
Thank you. In the Netherlands, from the beginning, I make clear to my patients that I do not communicate with them by email. And I do that to avoid that if you respond to a small question, like how long will the admission to the hospital be? And you say 2 days. Then the next question comes, and at a certain moment, the question is like, do you think my procedure is painful? And then it starts to become very strange. And often I forward the email to the secretaries, and they will respond then that Professor Rovers does not communicate with patients by email, and that they can always make an appointment by phone or in person. Then the other thing is about phone consultations. I tell my patients that phone consultations are intended for short communications and short questions. So sometimes they have like 20 minutes questions, and then I say that is not the intention of the phone conversation. It sounds a little bit business-wise, but it is to protect not only myself, but also to protect the patient.
Right. So do we want to hear what Clayton has to say? And if any of the people who are joining us, if you wouldn't mind popping in the chat. I know chat is new on this webinar, but tell us where you're from, where you're joining us from in South Africa or around the world, wherever it is. Pop it in the chat. And remember, if you have any questions, there's the Q&A. Sorry, Clayton, do you want to ask your question?
Yeah, thanks. It was just 2 comments, really. So one is also on this WhatsApp, email, various communication lines. One thing we are seeing more and more, and I think it's quite a good idea, is including it in your practice agreement. So your stance on that kind of communication, as well as setting up your right to charge for responding to that communication. You know, lawyers have been doing this for eons. I remember having to bill my time in 6-minute increments. If I pick up the phone and I speak to you for 4 minutes, that's one of my 6-minute increments. You get billed for that. If I pick up the phone and it's 8 minutes, you get billed for 2 6-minute increments. And so, you know, I think that is your time. Time is that's your product. It's your expertise as well, but you have to have time in order to do it. And it's how you bill. And so put in your practice agreements whether or not you will allow that communication. If you have restrictions on that communication, like only for follow-ups, post-surgery, or, you know, specific communication lines, and reserve your right to charge for it, or set your prices directly in the practice agreement to say, you know, even things like sick notes, etc., will be charged at a certain rate. So make sure that those things are clear to your patients. The second is just one other comment on the anxious patient. So, you know, one thing is to know how to respond to these. The second is how to avoid them in the first place. And I know it can't be in every case, but one thing that we in South Africa seem to be quite bad at implementing is the HPCSA rules around chaperones, and around offering chaperones for every intimate examination, and making it known that chaperones can be used for any examination or consultation at all, actually. And especially when you have a particularly anxious patient, or you have somebody, you know, who is nervous or who needs some support, offering them, making sure that they're offered a chaperone, they know that one can be present, and potentially even bringing their mothers with, can be one way to avoid that. Helps the patient, they've got somebody that they recognize and who's there with them to help them feel safe, and protects the practitioner, because you have another party in the room who can, you know, it doesn't become one versus one. You now have, you know, you have more viewpoints.
Thanks, Clayton.
Can I make a comment, sorry, about the chaperone issue? I worked in the UK for quite a long time, for about 5 years, and there for every examination you would call the nurse in to assist you. But when I got to South Africa, I mean, there just really isn't a culture or an expectation. But further than that, there's also sort of a slight discomfort with some patients at inviting someone else in on that. I don't think it's really done. I don't think it's expected. And yeah, I mean, I don't know. You've been a gynecologist for a very long time, Pete. I mean, you've got a great secretary. You could call in to assist you. You've got some other staff there. But I mean, what do you?
Well, the only time I've ever got into trouble with chaperones, actually, Clayton, is when a woman said, "Who's that other woman over here? And get her out of here. It's between you and me." So it's having a chaperone that she kicked out of the office. So I was somewhat chastened and humiliated by this, and I thought, well, I usually have a chaperone,
Yeah.
but you can. I have called on in on occasion, but I must say the patient finds it very funny that suddenly you're calling someone to stand there while you're doing an examination. So it's
in Spain, it is completely acceptable. We have now a guest from Spain here in Cape Town, and she was really surprised that I examine my patients without someone available. I explained
we should
that
actually sorry, carry on.
I explained that we have a lack of people and that it is quite expensive, and maybe our salaries are a little bit higher. So I do exactly the same. When I have one suspicion that something could come up, you know, a patient undressing completely, whereas I've not done that instruction or whatever. I mean, it's just also based on experience, and you can be wrong. But I would just find an excuse and will say, I get my nurse to assist me with the examination. Fine.
So both Deline and Lisa Welsh sort of are very comfortable in the space of consent. They work with the World Association for Sexual Health. So maybe they would like to give comment on what the world view is at the moment of nurses joining, chaperones, getting the consent of the patient for certain circumstances.
Deline, can we start with you as a psychosexual educator, counselor, and sexual health nurse? What is your opinion on that, chaperones? And secondly, I'd like you to tell us what is your most common intimacy disorder in your practice, please.
Thank you. Thank you for this. Yes, I've been listening to all of you, and I mean, just the term chaperone sounds weird for me, mostly because I also work with people in the sex work industry, and just the term chaperone sounds a little bit weird to my ear. For me, I think what's important is at My Sexual Health, we work through a trauma-informed lens. And of course, something like consent is very important. So the way, and I mean, you people working, you specialists working with patients for many years, I've seen thousands of patients. I get the feeling that you say you can feel the anxious patient coming in the door. You know it already. And I think it's the same for us working specifically in sexual health as well. So what we do is specifically at My Sexual Health, the practice, which is we have more than 60 credible sexual health providers in South Africa and also internationally. That's part of our team, and they've gone through quite some rigorous training processes. Even though we don't have specific training in sexology in South Africa, we have an accreditation process to be part of, to be seen as a credible sexual health provider. And one of the things is working through the trauma-informed lens, of which consent is important. So the way we work with our clients is very, we do not do any intervention of any kind without asking the question of the patient if they're okay with what we're going to do. We explain a lot. We stop when we see there's anxiety going up. In terms of chaperones, me personally, in the interventions we do at My Sexual Health, but depending on what is the intervention, we are usually 2 people in the room. So there's always more than one healthcare provider in the room, depending on, like I say, what the procedure is. So I'm not so used to the term chaperone, maybe because I haven't worked in public health that much specifically. But yeah, it all depends on the client. I mean, also what we have is informed consent before the time. So as soon as a client or patient make an appointment, it's all online. So they have access to all the information and all the procedures and what they have to know and what they have to prepare for, etc. So we make sure that they sign the informed consent, and sometimes it's quite a lot of information that they have to sign for. So we make sure they know what they're getting themselves in for. But in this space, we are, like I said, gentle, very aware of the individual in that space, and then we notice things as they arise and come up. That was the one question. The other question was, what's the most common? What did you ask? What was the most common?
Intimate relationship issues that you have in your practice. And then I'm going to ask Lisa to answer the same question, please.
Okay, currently at the practice, and specifically, I can only speak about the My Sexual Health Winelands practice in Stellenbosch that I'm sharing with Dr. Elna Rudolph at the moment. What we see a lot is sexual pain. I must say, especially amongst cisgendered females at the moment, we see a lot of sexual pain, and but also various other things, but mostly sexual pain. And then, of course, amongst the more the cisgender males, quite a lot of erectile dysfunction of the various kinds of erectile dysfunction. So those two we swing between mostly. But of course, anything else as well related to sexual health.
Okay, thank you very much indeed. Lisa, could you address that problem, please?
Absolutely. Thank you again also for inviting me here. It's been wonderful listening to everybody. There's just one thing I'd like to add about the chaperone and the consent question quickly. I also work as the communications lead for My Sexual Health. So I get to hear feedback from the patients who have seen the various doctors. And it's amazing how many women in particular are completely blown away by being asked for permission for a pap smear, for example. The idea that they've been asked for permission, do they feel ready, and allowed to feel the temperature of the speculum, things like that, and how that transforms their experience. And I also know one of the doctors in particular allowed a very anxious patient to do some self-testing. I'm not sure of the exact procedure, but she kind of gave her guidance on how to do this at home. And so then she felt more comfortable, and it just transformed her whole experience and future sexual health. Like, she wrote a very long, heartfelt letter about it. So that was just a thing I wanted to mention as well. So as an accredited sex educator, the biggest thing that I hear is low libido on both sides, cisgendered females and males, and also sexual pain that sometimes results in low libido, and general exhaustion that results in low libido, but people wondering why do they never feel in the mood, and looking for quick fixes most of the time, looking for a way to quickly kind of get in the mood, and thinking everybody else is kind of getting it on way more than they are, and wondering what's wrong with them. So it's often kind of normalizing their experience and validating and directing them to various, pathways that could support them. I think especially with sexual pain, the people that come to me don't often realize that there are many solutions out there, and they think maybe they're the only person who's experiencing something that sounds like vaginismus, for example. So yeah, that's probably the most common thing I hear.
Now, you brought up that interesting thing, Lisa. My patients, if you offer them half an hour extra sleep or half an hour's intimacy, they'll take the sleep every time. Now, what is your approach to women's low libido problems? How would you approach that?
I think sleep is a very valid option. I think normalizing asking them to look at their whole life and realize kind of where is their energy going? What are they being, especially if you're considering just a standard kind of maybe busy mom with a career, then there's just so many things that they're already doing. Their energy is being dragged in so many ways, and they often haven't prioritized themselves for a very long time. And particularly pleasure can feel frivolous. And so sex can sometimes become this kind of act that is another chore that they feel that they have to do. So reminding them of even the concept of consent for themselves, self-consent and consent within their relationship as well, can empower them to remember that they have autonomy over this, and they can take ownership of it, and that it's okay to actually save some resources for that, save some resources for pleasure, and maybe even find themselves fueled by it, rather than having just another thing that they have to do at the end of the day when they're already exhausted. So one of the things that I do recommend is scheduling sessions for intimacy and play, and connection either with themselves or with their partner, and allowing to see what happens. Because I think if you schedule sex and then, you know, Friday night it has to happen, it can actually cause a lot of anxiety and worry, and it can actually start to feel like this pressuring, you know, this pressurizing date in the calendar that you're actually dreading, which does the opposite of what we want. So scheduling play and intimacy, and just remembering that you can't do everything.
Very good advice. Thank you very much indeed. And we'll take that to heart. Just before I ask Professor Jan-Paul Hoovers the future innovations in pelvic floor surgery, I see in front of me over here is a piece of mesh. Steve, this is your this is your
mine.
This is your. We're sitting in your office. Where do you see the future of the use of mesh in gynecological surgery going forward?
I mean, it is a very much a hot potato. This is my office desk that we're sitting at, and I certainly do have a piece of mesh on my desk. This is a sacrocolpopexy mesh piece. It's not a, and this is still something I use, you know, every week in my practice, and I do a lot of sacrocolpopexy. So if you wanted to get the short answer, I see a mesh like this specific one fitting in the realm of laparoscopic repair of pelvic organ prolapse, and it's still very much a sort of a gold standard approach to patients, specifically those with vaginal vault prolapse, and it's still very evidence-based, and level 1 evidence suggesting that it might be the best way to, well, it is the best way to treat someone with sacro with vault prolapse,
Apical prolapse,
compared to something like a sacrospinous fixation, which is, in my opinion, an inferior operation, which is a native tissue procedure. So that is why I have this on my desk, and I discuss it with patients, and I think it's part of the consenting process and part of the discussion process. You know, having visual aids to patients. I mean, the other thing I have on my desk is this InterStim battery. So we have things, and I think trying to get the patient to understand exactly what their options are prior to surgery, and you know, using a lot of pictures, and also you know, going through complications with them in a visual format. That's probably the, you know, what I'd like to drive home as a follow-on to your question about mesh. I don't do any vaginal mesh at all. I know Professor Rufus does still do that, but the other role of mesh is in the TVT sling. And that is still, in my opinion, very much an evidence-based approach to patients with stress incontinence. And I mean, for the moment, it's still yet to stay. And I think it's an important operation that we need to keep doing.
Thank you, Steve. So as long as it's a sacrocolpopexy mesh for apical prolapse repair, or a TVT type mid-urethral sling, then it's kosher. Thank you for that. And Professor Jan-Paul Hoovers, future innovations in pelvic floor surgery, please.
Yes, thank you for the possibility to say something about the future, but I have to comment on the mesh as well, if you allow me, short. So I think we should not forget why vaginal implants, maybe a better word, were introduced. They were introduced to treat a group of patients who did not have high quality bone tissue as a way to do a tissue regenerative procedure. And the idea was that the implant would generate a host response, and as part of that host response, new connective tissue would be created. So an intervention for a limited group of patients, that was when it was introduced in the development phase. And I think that the field, the professional field, we doctors have not protected our patients enough, because we did not have enough guidelines. We did not say this has to be done only in clinical studies, but we left it free. And we know that some centers had great outcomes and some centers had poor outcomes. And those were especially the low volume centers who maybe did not well understand the principles of the surgery. The other thing is that if you look for an alternative, and that's my bridge to innovation, the first concept is mostly not the best concept. It's the same with cars, with planes. And of course, the question is, how do we protect our patients in that development phase? And how do we explain them that we are working on it. Every patient understands, of every person understands that the plane of today is better than the plane of 20 years ago. But I still have to explain on a daily basis, if I propose a vaginal mesh, that it is not for just no reason. We use 0.7% of cases we use vaginal mesh, 7 out of 1,000 patients. And we feel that for those 140 patients per year in the Netherlands, we would not have a good alternative. So the concept of tissue regenerative medicine, where we try to induce a foreign body response, needs to evolve the coming decades. It will not happen per year, but it will be a long journey. And that's also one of my fears with respect to the feelings and the emotions towards vaginal mesh. It should not close the door of that development, because if we would have stopped making cars when the first car accident would happen, then our patients of today would not have had access to the newest Tesla, which can maybe bring you home where you are sleeping. So what is new and what is innovative? All tissue regenerative techniques, and there are in fact 2 lines of thinking. One line of thinking is that the cells and pelvic organ prolapse are diseased and that you need to replace the cells. So by cell therapy, like stem cell therapy. That's one group. And the other group says, well, those cells are not disabled or not diseased. It is the environment that is diseased. So if we create a better environment where the existing and present cells feel more comfortable, they will again start to produce new connective tissue. That's my camp. And how do we try to establish that? By delayed resorbable implants, by hydrogels, and by electrospun scaffolds, and there are other techniques as well. These techniques are mainly obtained from other fields that are further developed, cardiothoracic surgery, aesthetic surgery. And it is sad to experience, and I have had indeed a lot of communication with Sherry about this, that for the field of women's health, especially pelvic organ prolapse, the need to invest in better solutions is not felt so hard as it is maybe in more male diseases. We have to continue to explain to the outer world that our current solutions are not yet optimal and that there is better technology to especially make the functional outcomes better. So our future is not about aesthetic surgery and make the vagina, as non-prolapsed as possible, because maybe that vagina polypropylene mesh could help to do that. But it is more about how we get it functionally correct. Micturition, defecation, sexual functioning, well-being, self-esteem, all these outcomes, that needs to be prioritized as a primary outcome for the future developments.
JP.
Yeah, I just before we move on to the next thing, I mean, JP, that's great. I love that comment, and I mean, I think congratulations to you for just keeping the momentum with the development of new products, and personally not giving up on what we're doing. Clayton has actually indeed put a very important comment into the chat box, where he says that HPCSA has recently reprimanded practitioners for not making patients aware of the option of having a chaperone present. And this is less about making the decision for the patient, but by bringing a chaperone into the examination unilaterally, but about making them aware that they may choose to have chaperone present, whether provided for them or to bring someone with them to give them comfort during the consultational examination. And I suppose that's the real take home, is that to actually give them the option. And maybe even having a little sign up in your waiting area. Is that an option, or should you just?
I've got a sign up, yeah.
What does your sign say?
If a woman feels the need for a chaperone, she must please make this known to the operator, and it will be arranged.
Okay, so maybe that's just the take home, is to provide them with the option. Great.
Yeah, but if you really want to make it unilateral, and I really liked that comment, it means that you cannot take the risk that there's any assumption. So it means that maybe you have to give a disclaimer when the patient walks in, something like behavioral rules? Do you realize that? Or maybe someone who welcomes the patient in your clinic and already explain that if the doctor forgets to propose it, that is an option. I really like that comment. I think it's a great point.
Important, and it's not a conversation we've had enough in this country, so it's very important. Sherry's got a comment.
I'd like to bounce back to the mesh commentary, and thank you so much, JP, for your insights. And I what you're exploring is priceless. It's important for everyone to recognize how much mesh anxiety still exists. There is never a day that goes by that we don't have questions coming into our especially our closed space, women going into surgery that have high anxiety because of all of the media exposure, and that and this made me crazy. All the media talked about was negative. It never talked about balance, the good versus the bad. And so the good stuff with mesh was never really openly shared in media. And that continues to generate anxiety in patients. So we do what we can to take that down, because mesh is a priceless tool in the right hands for the right patient. It's important to remember that. But I also like to comment on the regenerative medicine. This is a pivotal space that needs much more exploration. And we have got a significant sector of our following that have Ehlers-Danlos syndrome. And I can't help but wonder every day how that ties into the mesh complication scenario. These women that have got poor tissue integrity, and of course there's with 13 types of EDS, I mean, the degree of intersect varies from patient to patient. But we need to understand what's happening at that cellular level at a much, much more significant level to address the needs of that sector, because there are so many of them. So I encourage exploration in that space hugely.
Thank you very much.
Thank you for that. And then maybe there's one other group that we should not forget. That's the patients who have a mesh, but have no symptoms, and feel every day that they are carrying a bomb with them that will explode one day. So yeah, there's a lot of anxiety among them as well, and they are still our patients as well. Right. So indeed balanced. And I think that the South African gynecologist and urologist have to prioritize a statement paper. I've not yet seen it, and I have recommended it, where you just explain that implants, maybe a better word than mesh, for incontinence are different than implants for vaginal prolapse than for laparoscopic prolapse. Do not try to say these are good meshes and those are bad meshes, but just try to educate, because yeah, if we do not talk and not explain, then we create the distance, and then you cannot accuse the field or the society for taking their own conclusions.
Yeah, thank you very much indeed. We have some more questions from for our panelists. Our first question for our panelist is Lisa Welch. It says, does a female orgasm increase the chance of fertility? A question directed at Lisa Welch, please.
Hey, that is a tricky one, because I think the relationship between female orgasm and fertility is open for debate and ongoing research. So there's a couple of theories that could be relevant. There's a theory of sperm retention that suggests that the contractions of orgasm may help to retain sperm. That could potentially there's I think it's called the upsuck theory, that it helps potentially retain the sperm, and then there's more chance of the egg being fertilized. I suppose you could say then there are the psychological and emotional benefits of experiencing orgasm, which can help you to feel calm and in a good space without stress, kind of reducing stress, which could potentially impact your fertility. But this is an area, like I said, with ongoing research, there's no definitive answer on that. Perhaps somebody on the panel knows more than me on this, but that's kind of my answer on it.
Steve, do you know more than her?
No, definitely not.
Not on that subject.
No, and you?
No, not on that subject. I've got 5 kids. Now, hang on a minute. There's another very important question for Deline. Steve?
Yeah, I mean, I think it's, and it's again, just to Jeline and to Lisa, it's quite a broad question. How do pelvic floor disorders often impact sexual health, and what strategies can individuals use to maintain intimacy despite these challenges?
Also for Lisa Wilkes. No, for both of you. Can you start, Jeline, please?
Yeah, I mean, that's individual. That's the individual. It's not something broad. Every individual and every couple or reacts different to intimacy challenges or intimacy disorders. You can't, there's no general thing. But I think the one thing is people don't talk about it, especially here in the area I live in, Stellenbosch. People often don't talk about sexual challenges that they're experiencing. They often feel alone. And I think, yeah, to be able for individuals to reach out, especially to spaces like My Sexual Health, where we have an array of healthcare providers that work from the pelvic floor physios, that's absolutely specialists in the field of pelvic floor interventions, throughout our medical doctors that work specifically, throughout our psychosexual and sexologists, our therapists. So I think one thing that we know at My Sexual Health is that we work as a team together. We're not individual healthcare providers that works individualistically. We work as a team and we support each other as a team, and we refer to each other in a team context to give the clients and the patients the best support we can. Lisa,
Okay, can I just say, why would your people in Stellenbosch be less forthcoming and less open and less candid than Lisa's people in Durban? What makes you see a different case than Lisa?
I don't know. I think we're on the R44 with a big sign that says My Sexual Health. And it's not as if the patients are streaming in their thousands. So maybe it's just a very biased assumption that I made. It's also the practice is only 1 year old at the moment. So that is also maybe one of the reasons. And maybe people are not aware of our services. That's also a possible reason. People don't know. Because when I see clients, I ask them, where did you hear about us? And most of them would say, I Googled and I found you. So I think maybe it's our marketing strategy, but I don't know, because Lisa is doing a lot of work in that regard. So I think it is in general, I mean, our practice name is My Sexual Health. And I think in that, some people find it's still quite difficult to access it. Yeah, I think it's the stigma around sexual health in general that's still there.
Hey, Lisa, how would you encourage people to access the expertise you can offer them in such a way as to make their lives more meaningful?
That is a good question. I think, again, I want to say normalizing, because the question saying, how do these disorders impact sexual health? It can lead to people, obviously there's pain and discomfort, which can then negatively impact libido and then cause people to try to avoid any kind of intimacy. So I think it's important to teach people through whatever media outlets are allowed with this topic, which is difficult, but just teach people that it is important to maintain intimacy for the relationship if you're in a relationship, and there are nice creative ways of doing that don't have to involve penetration. For example, if you're currently seeing a sexual health provider that is supporting you in dealing with any painful side effects that you're having because of a pelvic floor disorder, teaching that there are other things that you can do. And I mentioned play the last time I spoke, but there are other forms of education. And as a sex educator, I would teach people of the importance of other parts of the vulva that can be pleasured, and other ways that a couple can be intimate together that are so important and can allow, it can help people to relax. It can help people to learn to communicate, and communication is key when it comes to any kind of pain disorder. And just teaching people the importance of not just gritting their teeth and carrying on, which is something that unfortunately I think a lot of women do when they're in pain. They still try to just carry on, and that can cause so much, as you all know here, that can just cause so many more problems. So just educating that this is something that happens and that there are alternative ways to maintain intimacy and that there are people out there to help. Because like Deline said, I think it's just that feeling of being alone, that you're the only one and you feel ashamed to reach out. And, you know, you don't really want to know what the answer might be because you think, oh, if this is affecting me, and, you know, it makes you feel like less of a woman if you're feeling pain during intercourse, for example. And just as the same that erectile dysfunction can make people with penises feel like perhaps they're less of a man. So yeah, education by just giving people the knowledge that there are other alternatives for intimacy and pleasure, and there are people out there to help.
Okay. Thanks so much, Lisa. There are two final questions or around the whole issue of the psychological and coping strategies for patients with sexual disorder. I think you have answered that to a large extent in terms of the fact that there is help available and, you know, creating awareness around the help that is available and trying to get people to open the conversation about it. And I think, you know, I think My Sexual Health and as a group and as a practice, I think you've, you know, really started to get a lot of traction in South Africa. The availability of an online consultation is amazing, I think, and I've certainly sent patients, some of my patients to you guys. And yeah, I mean, I think you guys are changing the paradigm. And I think, I mean, congratulations to all of you for what you've done. So, I mean, I think that's great. I think accessibility might be a bit of a challenge. And I mean, what I suppose, what do you suggest for people who don't maybe have the resources to access your care? Where do they go?
Lisa and Deline?
Yeah, that is a difficult one. I think through My Sexual Health sexology courses, we really try to educate all healthcare providers in the field of sexology and sexual health, so that even though they are in spaces where there's limited specific sexual health specialists, that the general practitioner in a small town in the Karoo of South Africa have access to training in order to assist people. Yes. So access in terms of financial access, this is hard. We still have to start a program with people in public health facilities to help them to be more skilled in sexual health interventions and assisting patients. I mean, they do that already, but very specific issues with regard to sexual pain, for instance. I think we all know in public health facilities, those nurses, they are very well in terms of managing STIs, etc. But more if we talk in terms of other intimacy disorders, there needs to be some scale up in trainings. So yeah, that is we are very well aware at My Sexual Health that these services are expensive for certain people to access. And yeah, it's still the way to go is through public health and assisting them to become more educated to assist other clients.
I'd like to.
Yeah.
I just also wanted to mention the vision of My Sexual Health as well, which is to accredit 10,000 credible sexual health providers across the global south in the next 10 years. And you know, the clinical head of My Sexual Health is Dr. Elna Rudolph, who is visionary leader, president of the World Association for Sexual Health, and she is doing everything in her power to make that happen. She really believes in this so fully, and it's her mission with her team to actually give the tools to those people who can make a change in all of those spaces where accessibility is difficult. So yeah, that's a very big part of our strategy, our vision, and that's what we're hoping to do, because as Deline said, at this stage, it is not always easy. While we offer online consultations, in South Africa particularly, these you know, visiting a sexual health provider, even online, is just out of reach, unfortunately. So we are accrediting people. We are accrediting. There's a nurse that Deline actually has. We've got a scholarship, and there's a nurse who's actually becoming accredited right now. And her aim is to create a youth space in rural areas within South Africa. So kind of that's our vision for the future.
Thank you very much indeed. Ladies and gentlemen, sadly, we've almost at the end. We have one more question. And that is
we are actually we're set to go until 6:30.
Yeah, but
This was an extended session.
yeah, unfortunately, our internet is going to be shutting down in a very short
Oh,
time.
dear.
I mean, Carrie. So what I want to do is ask the final question of Clayton. It's from Erwin Gertner. Can you bring it up, Steve? I think you've just removed it. I'd like to. Here we go. Great final PFFSA end of year meeting. Thanks, Clayton. Would medical aid funders, Clayton, be liable for the time and costs incurred in motivational letters and calls? Often the reply is that it would come from out of patient savings, often already depleted. Patients are then left with a bill for something they didn't ask for. Does that make sense, Clayton?
Yeah, makes perfect sense. And really, the question here, it's kind of twofold, because on the one hand, the simple answer is it depends on what the medical aids rules are and whether or not it says that it pays for these things, because they have the right to choose what they pay for. It's structured into the benefits. The second part of the question, though, is whether they do or don't, what should they be liable for? Because the motivation letter is really something that a medical aid requires in order to provide their client with access to the funding that they need to pay your bill. And it's a requirement from the medical aid. So if they require that you provide motivation in order to provide their own client with a service that their client pays for, I think it's rational to allow you to charge for that, because it takes your time and it takes effort. And you would charge for anything else, like a sick note or some other medical report. You would charge your patient for it. And so I do see a patient may get a bill for something that they didn't ask for, but ultimately it is something that should probably be discussed and disclosed between the patients and their medical aids as to whether or not that should or shouldn't come out of their savings. Because at the end of the day, it's not the practitioner who is requiring the motivation be done. As a practitioner, you could simply say no, in which case the patient doesn't get to have the surgery or has to pay for it themselves. If you think about the flip side, you could cause a lot of trouble by simply saying we're not doing this anymore unless we get paid for it. But I don't actually know what the real answer is, and I don't know what the medical aid funders are currently actually doing with this. But I do see the logic and the fairness in allowing practitioners to charge, because ultimately you charge for your time. It is your time. You're only doing it because it's required by a patient's medical aid, and it's the patient's medical aid to access their own funding that is requiring it. So for them to get a charge, and even if they did have a small charge because their savings are depleted, I don't see this as being something that is so onerous for a patient that you should sacrifice your time and the right to charge for your time for a patient's discomfort with their medical aid.
Yeah, I mean, just from a pure practical point of view, this is where it gets quite tricky with patients and leads to quite a lot of discomfort and uncomfortable discussions. And it's patients paying for sick letters, repeat prescriptions, and even this whole issue of a missed appointment. These things are actually quite difficult to implement. It leads to quite a lot of difficult conversations with patients. And I mean, obviously, it would, in an ideal world, one should be charging for these things. But I mean, I know how it's going to go. If when you start sending a patient a 2,000 Rand bill for motivation, I mean, do you do any of that? Do you charge?
No, I must say that
I mean, it's very difficult to implement.
No.
But I suppose if the precedent starts being set and the patients are informed about this by the medical aid, then that's fine. But I can tell you that no medical aid is actually going to be informing the patients about this. The first time they'll hear about it will be from us, and they really are gonna resist this. So yeah, it's a difficult conversation, and I don't think we're going to resolve it tonight. So.
That's right.
Yeah.
Well, Steve, I've just had a message from Professor Ruvus. They've got other Zoom meetings. Other people do have other meetings now. So unfortunately, we're going to have to draw the session, the last session of the year. And I'd like to congratulate all of those people that have been us tonight. Sherry, I do hope that we see you in Cape Town in 2 years' time. Enjoy your turkey tonight. And I'm sure, are you vegetarian or not?
No.
You're not.
Give me the
so
turkey.
You will be enjoying,
I'm a Wisconsin farm girl.
from Milwaukee. Steve, thank you very much for all your input. It's been wonderful. And traditionally, I do thank you for the use of your mini bar, and it has been very generous of you to do that. And then
depleted now.
It's completely depleted. It's looking very sick. So Darlene and Lisa, it's been wonderful to have you both. And of course, Clayton, you're always good value. Professor Ruvus, I'm sorry you have to go to other meetings, but it's been wonderful having you. And God willing, to everybody. And I'd just like to say the person we always, at the end of the year, this is season 4, episode 34. We'll be seeing you, God willing, inshallah, next year. And the person that's logged on the most, that wins the prize, is Dr. Erwin Gertner. He's the most satisfactory attendee. And thank you very much indeed, Erwin. And you win the prize. Ladies and gentlemen, a special thank you to Karin, who's our technical assistant and person that brings it all together. Remember, you do have CPD. We have some questions over here. If you do answer the questions, you do win. This is an ethics session. So the person that answers first wins an extra 5 ethics points. So it's something well to get onto immediately to win those extra points in the ethics raffle. So ladies and gentlemen, thank you once again. And God willing, we see you all next year. Thanks, Lisa. You picked up that joke. And we see you all bright and early next year. And Karin will tell us when we start. Thank you, Erwin. I mean, Steve.
And of course, from us, thanks so much to the indefatigable Peter Jong.
Indefatigable.
Thanks so much for keeping the momentum, keeping the sessions going. And Peter is responsible for a large number of the programs and the speakers. So we do appreciate that very much. And it obviously wouldn't happen without you. So we thanks a lot. And I think that brings it to an end. We see you next year. Enjoy your Thanksgivings and Christmases and holiday season.
And Hanukkah. Okay, thanks very much. Safe home and all the very best. Thank you, ladies and gentlemen. Safe home.
Thank you.